Greetings and salutations. Welcome, welcome, welcome. We are live and direct from the Central Hub of National Caribbean American Heritage Month, which is situated in Washington, D.C. But we're actually all over the world plugging in as people of Caribbean heritage, celebrating and commemorating our contributions to the United States of America and indeed the world. I want to say to the world because I want to make sure, even though we're focusing on the Caribbean, I'm sure the people in Canada and other places will be able to say the same thing. I just want to start off with some startling news to liven up the place a little bit and keep a little bit warmed up for what is going to come. We're talking about changing the future of the Caribbean, changing the future history of the Caribbean. These conversations we do are not just intellectual, conversations for the sake of having conversations, but because we're trying to come together as Caribbean diaspora, working hand in hand with people in Caribbean civil society to lay the groundwork for new foundations on how we build towards the future we want. And as we build towards this future, one of the things that's very important is access to health, health equity. And so I thought I would start off into the future a little bit with one of our uh, major healers. Some news about our major healer. He's long gone to another world, but I thought it'd be important to share something to keep you thinking.
Tickets go on sale in 5 days.
Okay.
Celebrate Festival. Fans of Bob Marley will have 100 million opportunities to see Bob Marley holograph in the Reggae Hall of Fame in the metaverse as tickets go on sale today. The event will begin on his birthday, February 6th, and run through May 11th, the anniversary of his death. Bob Marley's musical family, including great grandchildren, will join in a mass choir of 100 voices of musical stars from around the world. For more info, visit zytex.media.
So, welcome to the future. That future story set in 2045, honoring the 100th birthday of the late great prophet and emotional and spiritual healer, Robert Nesta Marley. We're talking about healing and health across the equilibrium or the spectrum of the health continuum. And so this morning we're going to be joined in our first session. We'll talk about what lessons have we learned from COVID, and how might we move the sector forward, looking at new ways of thinking about how we provide access and equitable service, and looking at telehealth perhaps as a way forward. There are other things I'm sure that will come up in the conversation. Following that, this morning, we go to the session on healthcare engineering and management systems, and then we go to complementary and integrative medicine. So we have three really strong, let's say, rounds of conversation around the issue of health matters. And I turn the floor over to our able co-host and co-chair of the Health Affairs Committee, Ms. Francine Hakim, who will take it from here to introduce our very special guest. Francine, the floor is yours. You're muted.
Good morning, everyone. Thank you. Good morning, Dr. Nelson. And thank you for this opportunity to bring this group together today. You know, working with the Institute of Caribbean Studies has really been a great experience for me professionally. It's helped me grow so exponentially and helped me to find a lot of answers to some questions that I've been that have come up in my career. And as I'm looking in the Caribbean region with regard to health, healthcare management, Um, and one of the things that I did find out, and I'm not even sure if you know this, this was just right before I was introduced to you, but I had done some cursory work looking at cancer, specifically breast cancer in the Caribbean region. And, you know, the conclusion that I came to really was very emotional for me in many ways. That's sometimes you got to be careful the type of work you do. You can become so consumed. But the conclusion I came to is that if you have a breast cancer diagnosis in the countries that I looked at, you need to seriously consider communicating and making arrangements to go to stay with people, family, friends who are in a first world situation, in a first world location. And funny, you know, it might just sound simple, you know, because I finally have the words to put the information together. But during this journey with putting this telemedicine seminar together, it gave me an opportunity to really dwell a little bit further into telemedicine and the role it plays in healthcare management in the region. This journey took me initially to, I met a gentleman on the way here, I think is Dr. Ed Stevenson, and I'm saying his name because I'm hoping that we will continue to be in communication. He would not be able to make it today because his organization is having their seminar similar to ours today, and it will be focused on telemedicine in the region. There are some situations that are established and seems to be hopefully areas to grow. The survey that I did with the locations that I am familiar with, telemedicine was not part of their practice, but however, there is interest. So this telemedicine piece is answering a lot of questions that I've been having. And I look forward to today's discussion, and not only also looking forward to convening with Mr. Ed Stevenson and the panel that he's put together. We have today with us Dr. Glenville Liebert, who is from Nevis, West Indies. I know Dr. Liebert for a very long time. We've made projects together in the region. I want to introduce him as part of our panelists today. I also want to introduce Dr. Pierre Vigilance. I'm just coming to find out, good morning, Dr. Vigilance, learning some more about him, and I'm sure he'll be able to tell us, give us a better introduction of himself as we move forward in the topic of today, and that is telemedicine. Where has it come? The impact that with the statement I just made, it's not only the pandemic, it was probably pre-pandemic that became very popular. And so now the pandemic has gave a platform like telemedicine an opportunity to escalate. What does it need to be successful? Where are the glitches? Can you bring us some light to us, Dr. Vigilance? Let me see. Am I doing back here? Can you bring Dr. Vigilance to the forefront here?
Certainly.
Fantastic.
And good morning, Francine. Thank you for having me, and Dr. Nelson too. Thank you for inviting me to be part of this. Just by way of background, very quickly, you see in my background, Agri-Business Health. I'm the Vice President for Population Health and Social Impact, and also the Executive Director of our foundation. Agri-Business Health is a relatively new company. We're a startup in the health technology space. We create networks for healthcare and research that leverage both blockchain technology, which is something that we might get into a little bit here since we're talking about future states, and artificial intelligence, which many know as machine learning, and put those two things together to create the networks necessary to improve health outcomes, both within the healthcare sector, as well as life sciences and community health and research. My background, clinically trained in emergency medicine. I was born and raised in the UK. My parents are from the islands. My mother's Trinidadian, my father's Guyanese, and came to the States in my late teens. Emergency medicine trained, spent some time in government, was the health commissioner for Washington, D.C. for a few years and health commissioner in Baltimore County, as well as spent some time in academia. So I was an associate dean at the School of Public Health at GW for a little bit, and now in the health technology space. And I like to say that this telehealth conversation is really about more than just telehealth. It's about access to technology, particularly relating to low middle income communities and the disparate lack of access that those communities have experienced globally. And COVID, as you mentioned, Francine, has sort of been this thing that's ripped the Band-Aid off and shown us a number of things. But the issues and the challenges with respect to health inequities, health disparities, biases in healthcare, et cetera, with respect to access, with respect to care itself, these have been long-standing issues, particularly for underserved communities. And the telehealth boom that we've seen in the last couple of years that has been facilitated by COVID has also shown us a number of the disparities in the digital environment, in the digital ecosystem that exists currently for different communities. I mean, it's easy for health systems to set these things up to some extent because they've got the resources to do so. But at the community end, there may not be the access to the technologies or the awareness of the ability to use them that will enable people to fully realize the potential for telehealth and telemedicine. So I'm looking forward to this conversation.
Thank you. Thank you, Dr. Vigilance. Okay. Okay, Dr. Glenville-Liebert, can you turn your video on and bring us a couple of words to tell us about your interest in telemedicine, telehealth? I know that Dr. Liebert and I have worked on a couple of other projects together, and I always seek his opinion on topics in the healthcare and healthcare management system as it pertains specifically to Nevis and also in the region. Can you introduce yourself, Dr. Liebert?
Sure, certainly. Thank you very much, Francine. And thank you very much, Dr. Nelson and team, for this opportunity to be part of this very important conversation and bringing the diaspora together, linking resources to help the under-resourced Caribbean islands. And as Francine would have indicated earlier, I am from one of the smallest islands in the Caribbean, but we have a very proud legacy. And we have aspirations of greatness on that island because we have made a great impact on world history. Lord Nelson hanged out there, helped build the British Empire. Alexander Hamilton was born there. He formed the US Constitution, and Cicely Tyson, great actor, was born on Nevis. Her ancestors came from Nevis. So we have lots of important personalities. For a small space, we have produced more test cricketers to the West Indies team than most of the bigger islands. And we were the first island to produce a cricketer from the Leewards onto the West Indies cricket team. So we have that track record of greatness. And for myself, I studied medicine at the University of the West Indies. Did my internship. I studied in Jamaica, went to Barbados for my final years, and Trinidad for my internship. Came back home, spent a year, then back to Barbados to start anesthesia, and then off to the UK, Glasgow, Scotland, where I finished my specialty, gaining a fellowship in anesthesia from the Royal College of Anesthesia, both in Dublin and in London. So I have a double fellowship in anesthesia because you have to do 2 exams, which are for both exams to guarantee that you'll pass one or the other, so I passed both. They came back home in 1996 to make my contribution to the development of my little island called Nevis, which is dear to my heart and home. So they said, no matter where you roam, Nevis is still your home, and
absolutely.
Then you'll want to keep coming back time and time again. The tranquility, the friendliness of the people, and the informality, and it can get very intense, though small, And I've been back there 26 years and never have a dull moment. Trying to innovate and bring systems to the island that exist in the first world. So when I first came back, focusing that I want to bring a New York type healthcare to the island, and yes, I had my vision, my dream that Nevis will want to become a mecca of healthcare, where people will come from anywhere in the world and want to have the healthcare on Nevis. And I have been privileged to see the health system there transform over those 25 years since me back home. From 4 doctors assigned to the hospital, we now have about 26 doctors assigned to a small hospital with just 50 beds. We have 2 surgeons, we have 2 OBGYNs, 2 anesthesiologists, we have an internist, and a plethora of primary care doctors in the emergency room. We have 2 pediatricians. So that has been part of my legacy, to stimulate change on the island, using my skills in anesthesia to build a stable health system. Because during my upcoming, I will observe the surgeons will come and spend a month or 2, and then they leave because they can't do surgery. But now the surgeons we have been there for the better part of the last 20 years. So we have a stable surgical team on island. We have 2 general surgeons, 2 or 3 OBGYNs at best of times. And so we have visiting neurosurgery, visiting orthopedic. We have orthopedic surgeon as well, no resident on the island. So the system has grown in my short lifetime being back home. So I will pause for now, and later on we could get into the conversation about how I've used my link with colleagues abroad using telemedicine in small and big ways to get help for my patients and for myself as well. Because my wife had her own issues, and through linkages with doctors abroad, we were able to access healthcare which couldn't be delivered on the island. And we have shared that experiences with many others who have also benefited from my network of contacts around the world and the Caribbean world.
And that's actually a good place to start, creating the networks. So now I see we have Dr. Edwin Bonongo, is he available? Okay, I didn't see, sometimes people can make arrangements to be a part of the discussion, and sometimes it can't happen, especially if they're a physician. So you know that. So we'll move forward from here. So Dr. Vigilance, can you tell us about what it needs to what is the platform? What's the foundation of telemedicine? Okay, we're talking about communication and establish a communication system. Is there any particular requirements, like in a formal telemedicine situation? Okay, right now we're on Zoom. Right now we're on a recorded situation. Are the situations recorded? Are there any security or confidentiality concerns from a patient standpoint, from a physician standpoint? Can you talk to us a little bit about something along that topic?
Yeah, 100%. So I think there's a couple things that we have to understand. Telehealth is more than just the opportunity to be able to see a provider in this virtual space. It also involves things such as store and forward, which is the ability for data to be stored in a particular place and then forwarded onto another provider. If you have images, radiologic images or derm images and things like that need to be sent to somebody, they can also be sent using these platforms, albeit not in the live setting. And then you've got some very sophisticated settings where you can actually have live transmission of data during the visit itself. So, being able to see what somebody's heart rhythm is in real time, being able to look at a particular part of someone's body or in someone's ear, for example, or down their throat in real time. So there are multiple opportunities. From a systems perspective, at the user end, there is a need for decent bandwidth. And when I say bandwidth, I'm talking about how fast is your internet connection. And that's one of the challenges. I'm based here in the United States, and there are many different broadband opportunities here, commercial and from the government sector. And when the government offers broadband, it has often offered broadband at a bandwidth that may allow for one person in a household to be able to do a number of different things like we're doing now, for example. But if there's anybody else in the house doing anything else, homework, streaming any kind of video, doing anything else, that takes away from that bandwidth and might impact this interaction right here. So having broad bandwidth, wide bandwidth, at millibytes per second, that number, and that impacts the speed and the patency of the connection. And might actually, you may have been on Zoom calls where the connection wasn't so great, so you may have had to drop your video just so you could hear. The benefit of telehealth is being able to see and hear somebody. And that's when you're doing it maybe on a computer versus doing it on your phone. Benefit of doing it on your computer being that you can have multiple windows open. But if you don't know how to make use of a multi-window environment like a PC or a laptop, and you are using your phone because that's what you have access to, then that can create some challenges too. So there's the hardware end of things with respect to the connection and the speed that's available to you, which can be impacted by cost, because the wider the bandwidth, the more costly the connection. And there's the patency of that connection. Is it available to you all the time and anytime you want it? And then there's the hardware that you're making use of, be it your phone, a laptop, a desktop, etc., and your knowledge of and ability to navigate those spaces. I think most basically, those are the elements, and they're not as ubiquitous as one might think, if they are available to people, they may not know that they can do all the things that I just described on that particular device because they haven't been coached, if you will, on how to make use of it. Does that help answer that question?
Yes, it does. And it makes me start thinking about some things. Dr. Liebert, this sounds like a great opportunity to build. What do you think? Anyway, I know you're with me. I know you're here. So if we were to put a conversation together to build telemedicine, telehealth, we would definitely need to, it's not just a doctor thing, so we need to have an IT person, an IT company, a strong IT foundation.
Well, definitely, I mean, we need the technicians to troubleshoot the hardware, to make the connection, the networking. We need to have access to the primary connecting platform, to the service providers, I mean, cable and wireless, Digicel, and those who own the main fiber optics networks, etc., and get them to open it up, make it more accessible to the ordinary job log on the street. You know what I mean? If your patients can't connect with you, then it's no value to the system. And if only doctors could speak it among themselves. So we need to be able to have every
security
must have access to the platform in real time, so that they could consult with their providers at whatever level with the security built in to the network, you know. Okay. I mean, right now WhatsApp is becoming a useful platform to just make appointment connection, to share information, but there's limitations to that. And through the pandemic, Zoom became even more relevant as people begin to realize they need to converse. And since we cannot travel, then WhatsApp was limited in terms of the face-to-face interaction. So Zoom provided that. And so many of us in the islands have been doing 3 or 4 Zoom meetings a day. You know, some we have 3 going simultaneously. So you have to pick and choose which one you listen to. Sometimes I have 3 devices, you know, my telephone, my tablet, my desktop and laptop going at the same time. I'm switching between conversations, you know. So that's the way technology has been evolving on the island. Right. But of course, the bandwidth, as you said, you have to turn off your video sometimes to get a good connection. And that can be very frustrating at best of times. So thank you very much, Dr. Vigilant, for highlighting those issues.
Yes. So, and one thing I really want to make sure we talk about also is the cybersecurity. I know we're going to be talking about cybersecurity later on in the week. Well, we're talking about security. I'm sure there's a cyber situation there. But anyway, cybersecurity and that whole, cross check about your personal information and access and who has access. I remember when in the very beginning with Zoom, there were people who were, they call it, breaking into different people's meetings, I think security is going to be a very good issue, an important issue to be of consideration. Okay,
Yeah,
And
wait a minute. So before you jump off of that, so we're talking about cybersecurity. We're talking a little bit about the bandwidth, and I'm wondering, we're talking about first of all the infrastructure. So the infrastructure is clear. We're not sure if the Caribbean is ready. Certainly here in the United States, some households aren't ready, and Dr. Vigilance may be able to speak to that. I know at some point you were very active in Baltimore, which has so many hotspots of poverty, deep poverty, right in the city, that in a way it actually parallels the lessons that we're being able to beginning to observe coming out of a city like Baltimore with deep intergenerational poverty and deserts, if you will, may actually parallel that some of us we have to do in the Caribbean region. Part of the reason why I think this conversation is important for us in the diaspora who do so many medical missions. So many doctors go down and do medical missions in the region. Jamaica has, I don't know, maybe over 12 to 24 groups that are down there at some stage or another. And actually, during COVID itself, they were down on the ground in a makeshift hospital in the western part of the island providing care. And I really had hoped to have somebody on here who would talk about that experience providing service during COVID. But when you come back to the cybersecurity, I'm wondering, Dr. Vigilance, if you could speak a little bit more to that from the point of view of what is now unfolding in the US regulatory system, right? Because it's not just the actual effect. It's if something happens, then what? So what is unfolding in the system? What are you hearing on the ground?
That's a great question, and you could dedicate a day to this sort of privacy preservation and security conversation for sure, particularly in the health space. But I want to preface my comments by saying that health is more social than medical. And what I mean by that is that while the medical system and what the system that Dr. Liebert is referring to of providers is incredibly important and a cornerstone element of being able to provide care, what we do on a day-to-day basis, how we get places, how well educated we are, where we live, if we have a livable income, what kind of work we do, all these things impact our health and health outcomes.
Absolutely.
Now, why do I mention that? I mention that because that is the context in which people live, regardless of where they are in the world. It's impactful of your outcomes and how you move through your day-to-day life and what you're able to have access to. When we start talking about security, when we start talking about privacy and the preservation of that privacy or security with respect to your data, that's to some extent a function of infrastructure and also, sophistication, if you will, or maturity of your system. So there are systems in this world, in different parts of the world, the Caribbean region, and also where I've done a bit of work and on this particular issue, and also in sub-Saharan Africa, where there are paper records still being used, if you will, as the primary record in the health system. So people literally, and in India too, people literally have stacks and stacks and stacks of paper. That's their record. And digitizing that record is an important step towards improving the portability of those records, being able to share those records between different providers. But then you start asking the question about, well, is it safe for me to do that? And these are all things that are aided by cryptography, if you will, or systems that allow for improved security of the data itself, and systems that are multi-layered, that don't allow somebody to just walk into a digital room, if you will, and take something, but they have to have a particular key in order to get into it. And if there are changes made to your data that don't vibe with what is known to be true, then that is flagged by a number of different people at the same time, maybe on a distributed ledger, and that improves the security of your information. But all of that can be true. All of this technology can be in place now and into the future. But at the very end of the day, people have to trust, individuals have to trust that system or those systems are actually patent and actually do work. And what happens with the news cycle to some extent is when we hear about these breaches, People hear about X thousands of people whose
Okay.
data was exposed in this
Right.
financial system or this medical system or in this other system from various places, then people say, oh, those systems are all tainted and they're all prone to being hacked, etc. And I say that there are malicious players out in the world who want to do those things. But I find we're also we can talk out of both sides of our neck to some extent, because while we're very concerned about security and safety and privacy with respect to our health data, we will go on Instagram and take pictures of ourselves doing all kinds of random things and post them without a question about whether or not we're concerned about privacy in those particular settings. So we need to be balanced, I think, and be honest about what it is that's out there and what's happening. And the privacy preservation conversation, to your question, Dr. Nelson, specifically, is becoming a lot more upfront. People are talking a lot more about personal data ownership, meaning that you as the individual own and have the right to be able to share your data with who you choose to share your data with, as opposed to your data being shared by the institutions and enterprises that gather it and to some extent sell your data for their profit, right? And be that a social media platform or a health system or a hospital. There are a number of different places and ways in which once we sign off on or we hit agree on that new app that we just got, and we're consenting to a bunch of stuff that we didn't read because we scroll through all of that and we hit agree. We don't really read the consent forms when we go to our providers. And to some extent, those need to be simplified and the systems need to be emboldened such that people can feel comfortable that their data is not going to be provided in an inappropriate way, in a way that doesn't benefit them, and in a way that they can't control. So what's coming is more personal data ownership and more personal sort of sovereignty, if you will, with respect to your data and the ability to share that information, which is going to be requiring of us to upskill people around where their data is going now, so that they can have an understanding of what they need to be promoting or preventing in the future.
Yes, and I know, when was it? I can't remember when it was. Dr. Nelson and I had the honor to launch the Health Research Institute at Hampton University, and EMR was one of the topics there, and the movement towards EMR. Yeah, so that is, I think, as we're getting to more people are becoming digitalized, I think we're going to see more of paper, transfer paper to digital. Okay. Now, I liked that Dr. Nelson kind of paralleled your Baltimore connection almost with the how would you say, the landscape of this of the social landscape, looking at the social determinants of health. This is what I see that you were picking up on, and how it impacts the whole gamut of things. We're talking about being healthy and we can't guarantee that the food is safe. You talk about being healthy and we can't guarantee that the water's safe. So, and it's hard to be being healthy when you can't afford to have proper housing. So they all, do go hand in hand. And thank you for bringing up, the different determinants of health that we need to keep mindful of. Okay, so we're at the 9:30 hour, and we're going to, let's see. Well, I'd like to talk a little bit more about the COVID recovery, and what technology do we think would be helpful in the recovery? When I say technology, I'm talking about, so right now we've gotten the test kits down. Where are mine? Everybody got to have test kits somewhere, real close to you. And that, first came from a very, setting up massive labs, processing many, many samples. We're talking about to now being able to have a test kit on your desk, and you're going to go into a public situation and So it has evolved. It has evolved. And that has evolved with technology. What are some of the technological things, that we're going to be seeing, okay, in this future, looking at the future of medicine and the future? Well, we talk about telemedicine, but just in the future, what do you see? I tell you,
But I
I
think it's
saw.
relevant because let's think about it this way. As an engineer, I'm not a medical person, not in the health field, but certainly the technology, the engineering equipment, we're seeing these home test kits, for example. Now, these things are available in the US context. The question is, can the Caribbean get to the stage where we can have similar, let's say, kits, even if they're not home test kits, at least in rural community centers or in small islands like Nevis, which is not, let's say, in the mainstream of things. Where do you see that going, Dr. Vigilance? You're here in the US, and I know one of the things that we're talking about this from the point of view of the technology, but the issue is also the financing of this thing. Is it that the technology and the financing of the industry go hand in hand, the politics around the financing? What lessons can you glean from what has been happening in the US context for people who are in Medicare or in the government system or don't have healthcare insurance, which are all things that we are used to having in the Caribbean region? What lessons can you put out there that we might want to think about?
Well, one of the things that immediately comes to mind is the assumption that low middle income communities that are making use of Medicaid, for example, do not have access to what we'll refer to as edge technologies, sort of like smartphones, right? There's a big assumption that those communities don't use those technologies. Now, I did highlight at the beginning that there are disparities and inequities in access to affordable broadband and to affordable wireless cellular programs too. But that does not mean that people in these communities don't have access to and don't use wireless and smartphones specifically. I can't tell you how many young people want to plug their phone into my house right here in Philadelphia just to keep a charge on the phone because they're using it so much during the day. And I make that point only because I know there was, I think, an interesting study Deloitte did a few years ago, 2018, where they highlighted the number of Medicaid patients who are making use of their smartphones for, say, medication compliance or to keep appointments and the like. Now, again, if to some people, surprisingly high numbers of those surveyed in the Medicaid population making use of these technologies. And I think that that's one of the first things that researchers and the municipal leaders, et cetera, have to get out of their heads is that those communities, in quotation marks, don't use those technologies, because they do, and they are. And what we need to do is empower them, if you will, and empower all of us to be able to better make use of those, because that edge, if you will, and when I refer to the edge, I mean, remember we used to have cyber cafes back in the day, the place you'd have to go to get the internet, because you couldn't get the internet at home. You had to go somewhere to sit in the cafe and pay money to get access to the internet. Now, when you go to the cafe, the internet's free. But, there you go, and there's now affordable, to some extent, internet available for you at home. So you don't even have to go to the cafe if you don't want to, or the store to get access to the internet. And care is coming home too, right? This is what we talk about with respect to you talking about test kits. There's a bunch of other elements of care coming home. Telehealth is another element of care coming home. Care is also becoming more portable, which is not just needing a laptop or a computer in your home, but being able to engage in care through your phone, right? Like we talked about before, being able to use telehealth through your phone, but also to store your information in your phone, to have your health wallet, your personal data estate in your phone. And this to some people sounds like Star Trek, but it's 2022 and we're there, right? This is not a future state. This is now, but it's not now for everybody. And that's where the challenge is. And that's what we need to work out is how do we make access more affordable such that people can have what the 1% have on their phone and have access to on their phone with respect to portability and access, that can be something that we make available to everybody, maybe in different flavors and ways, but something that we make available to everybody. So I think that the movement has been, if you will follow that cyber cafe through to the home sort of line that I was referring to before, similar to currency. I mean, who would have thought that, before you'd have to barter my sheep for your dog, and that would be the exchange we would make. And now we're making transactions. I can buy something from somebody on the other side of the world without sending them anything by mail, if you will. I can do this electronically in a heartbeat. And I think that it's, you tell somebody that was going to happen 50, 60 years ago, they tell you were crazy. And so we need to be leaning into these opportunities now for everybody and putting the underserved communities at the front of line for innovation.
I want to just jump in. You said something which really caught my attention, this personal data estate. And I start thinking about to step back and look at the culture of care. Because the culture of care, Dr. Liebert and Dr. Vigilance, I'm not sure when last you've actually seen a patient, Dr. Vigilance, you've been so much involved in public health, but the culture of care in our community in the past has been very much to give over. It's actually been a dichotomy. Either we're very suspicious and we see at home we drink the bush tea and we drink the base and we mix a proportion and we stay away, and bush tea is the way to go, right? Or when it's really bad, we give our responsibility to the doctor who knows all. And so, but I think I want to hear from Dr. Liebert, who's on the ground. Where is the culture of care in the Caribbean in terms of the primary care physician, the patient? Is it changing where the doctor expects the patient to have more responsibility and knowledge now that more people are going to school, educating, have passed their CXE? It's not the patient of 1962, 1970 either. These are more sophisticated. But talk about the culture, because you cannot drop telemedicine, telehealth, wholesale as it's practiced anywhere in the world. And we hope to hear from the people in Africa later today if they're able to join. But tell us more about the culture of care and how that might impact how the lessons of COVID could transform telehealth or move us towards telehealth in the future.
That's a very good question and observation, Claire. And, my experience has been that people, sometimes we underestimate the ability of the common man on the street to appreciate health technology and to understand the medical language that we quote. And the paternalistic pattern of care is still very prevalent in the islands, where it is, though, as I say, you can't ask the doctor a question, you can't challenge what the doctor is ordering you, And we see a lot of this in the COVID, the hesitancy to take the vaccine. And I can show you that as a doctor, I argue with the authorities that they went about it the wrong way. Yes, the vaccine is a good technology, but it was given a bad name by the way it was promoted, and the use of fear and strong arm tactics and railroading the population to take the vaccine. And most of my patients, when they come and we sat them down and we reason with them the pros and the cons and why you need to be safe. Safety first. Know your risk factors and then decide accordingly, and know how to mitigate any complications that could arise. And invariably, whether they were 20 or 90, 80, they were willing to take the vaccine because having understood, look, this is a personal responsibility. I have to know how to protect my health. Then they begin to say, yes, I have diabetes, I have chronic lung disease or whatever I need to protect myself because if I get this immune challenge, I may survive it. But a doctor is there who is willing to work with me in case I have any complications. And we, they went and they took the vaccine. And so, but the level of education that was coming from the authorities were not always at that granular level where people were empowered to be part of the conversation. It was do as I say or else, you know, and that caused a lot of problems and social rift.
Yeah, we talked about that.
And but
Demanding.
when it comes to uptake of technology, I mean, we see everyone now have a glucometer in the house. Everyone have a blood pressure monitor, a thermometer, and patients have WhatsApping me their oxygen saturation, the temperature, the blood pressure recording, and we're consulting via WhatsApp or by the phone. I say, okay, well, you may need to come into the office to give them a better understanding and to double check certain physical parameters. But it is already there, but we just have to make it more accessible. And that A word keep coming, accessible, affordability, you know, but the governments have a role to play to break down the cost barrier, because I remember when a computer fill a room this size, but now the same power of computer is in the palm of your hand. You have 3 or 4 in your bag, you know. When I first went to UWI, we used to line up outside the computer room with our punch cards to give to the operator to give to run a program for us. But now that power is now in the palm of our hand. And that is just in the last 30, 40 years of this transformation in technology. And so by democratizing the computing technology, everyone now have access to it, but there's a lot more to go. We out of the bandwidth, you know, and the data ownership and so on. So we need to address these issues, but participation of the common man in the public is key, and giving them the power that, look, we can't take it for granted because we need your customers, we need your services, you need to be part of the system, and that's how everyone will benefit going forward. We can't just have the 2% at the top and the 90% just there standing in line to get a little, you know, 5 minutes of internet access time. No, that can't work. Everybody need to have equity in the system. And so that's my point, mate. But it is possible,
Yeah.
it is doable. And during COVID, we saw it happening. I mean, people who you think couldn't do Zoom call, they had to learn it. I mean, the teachers, the students, some students haven't gone to school after 2 years because they were learning virtually. And so that giving every child a tablet or a laptop, you know, is part of the way forward, and giving every granny a smartphone where they could have a seamless interconnection so that they could FaceTime with the children in the diaspora, you know, and they could send a prescription to the pharmacist without having to leave the house and have someone bring it for them, or have a drone deliver the prescription back to the home. You know, all these are things that we need to explore going forward.
Dr. Liebert, that's something that you said there. I was thinking the other day, the technology, the advancement in technology over the last even 20 years, you know, I remember has just been exponential. Just the phone. I remember when the phones were the size of a brick. You know, now they're something so small. One thing about technology, I had the occasion to meet someone who was into medical technology, and one thing that they were describing to me that was going to be coming in the future, or they have plans of it coming in the future they're working on, is a way that they can discharge a patient with some sort of patch that's giving them heart rate, blood pressure, and other readings. And I'm not sure about the connectivity, but I'm sure the cell phone is the connecting point there. I'm not sure if it's with they get scan a QR code and can they get followed? I'm not sure how it goes, but with the advancement in technology, there's going to be a lot of different ways that we can seek wellness and healthfulness. Let's see. Anybody else have any questions?
So let me get back to where we're trying to go. So we're trying to figure out what are the things that will take us to a new normal, right? We don't want to get back to the old normal. We already saw how many flaws there were in the system. We had the flaws in terms of access to testing. In the Caribbean, laboratory care, access to testing itself is a problem, right? In terms of Some rural areas, they might have someone who can draw blood, but there's no lab in the rural area. So I know there are things that are changing in that industry, but even here in America, where every corner has a test. I'm not sure if you have been seeing the stories about what's happening in China, in Shanghai, where there are like kiosks that they have to go to, and every couple of days they have to do a self-testing of their status, and they have a thing on their phone, right? This is really like a dystopian future, right? They have a thing on their phone, and if it's red, they can't go into a building or they can't do certain things, and they have to go into a quarantine place to quarantine. Now that's the future that China is creating, right? In terms of how they intend to care for a post-COVID healthcare system and public safety system. I don't think it's going to work in Caribbean. It's definitely going to work in America. There'll be like a revolution. The second American revolution will definitely take place. But as I thought about, oh, so there is a possibility then that we can have a healthcare kiosk system in rural areas. We can, just like how the pharmacies became de facto testing stations and temporary testing stations were made in, in community centers. It means that if America really wants to have a more equitable healthcare system, these lessons of COVID can really be applied to the healthcare deserts in America. So my question is, Dr. Vigilance, what is the conversation again? You're on the ground talking to different people at different levels of the system. How are people reflecting? The people who are driving minority health and health equity conversations, how are they driving the advocacy then for the shifts that have to take place, using COVID as an example in terms of creating community level testing stations?
Yeah, and community level buy-in. So what I've seen from different local health agencies, and I'll shout out the place I used to work, Washington D.C., and Dr. Nesbitt for the strong work that she and her agency have done in this particular area. It's fair enough to have everyone be able to sign up for testing, or sign up for these testing slots electronically. But if your access to or understanding of the system that is online for you to be able to do that is limited, then the people who are going to sign up for those slots are going to disproportionately come from communities where there is greater access and maturity and knowledge and awareness of the digital systems, right? And so what they decided to do was, in order to ensure that people had equitable access, was to limit your ability, if you were coming from outside a particular area, to just flood into and be able to get tested ahead of other people from an immediate local area. And some of that required some door knocking, some of that required some actual community connectivity and some conversation with people directly. And I think that many agencies around the country and globally understand, and sometimes in other parts of the world, maybe more so than the US, where this extension piece that I'm about to speak to is a bit more common, that tech needs people, but people need tech. We need both of them in play. You can't just have technology and say, here's the tech, and leave it out there for people and expect for it to be an equitable system. Nor can you sort of say, well, we won't have technology out there and that will allow us to be equitable. You need both. And the people part of the equation that I'm seeing come into more play now is this extender of the healthcare system into community with people who are not the physician or the nurse, but maybe it's the social worker and the case manager and the community health worker or the promotores or some of these other care extenders. Again, not to take away from the utility and significant impact of those frontline providers, i.e., physicians, nurses, etc., but to suggest that we need some intermediaries and we need to make better use of intermediaries, people who can facilitate maybe access to different services, be they community-based or clinically based, and also facilitate the use of technology in this whole system. So, the digital community health worker, if you will, which is a real person, but somebody who can not only improve your ability to access care, to go see Dr. Liebert, etc., but also facilitate. Dr. Liebert wrote a prescription for you to take something in particular. The step before you using your phone to be reminding you of this is to have Pierre, the community health worker, come and visit you and talk to you about what it is that Dr. Liebert needs you to take, and have you got your medication filled yet, and ensuring that some of these gaps are being filled once you leave Dr. Liebert's care, be that in the hospital, be that in the hospital or in the clinical or in the ambulatory setting, because that's where we lose touch with people. And some of that's going to be technology, and some of that's going to be people, and some of it can be people and technology. And I think that class of worker, if you will, that workforce diversification is something that I see happening. In the US, a lot of that is predicated on reimbursement. So there's that part of it. How do we pay for it? And that is a question we need to address in the Caribbean too. But I think that those are some of the ways that we can improve outcomes by engaging a broader workforce of people to facilitate that gap, filling that gap between what happens in the clinical setting versus what's happening in community.
You just really hit the nail on the head, and it really reflects on something you said. Dr. Liebert, I see your hand, but I was going to come to you because this is exactly what made me very irritated when this thing unfolded in 2020. I was talking to some people who were nursing students, right? And they were their final year students. And they were sent home from school. School was closed down. And I'm saying to myself, you have final year nursing students about to graduate. You have a pandemic. And you mean to tell me the government of Jamaica could not create an education class out of these students, give them something to do, right? Train them up for a week or two and send them out to be a community health informants or something to go and take data, etc. So Dr. Liebert, I saw your hand up, so please jump in, because I remember being very angry at the lack of forethought and foresight and strategic thinking in the region. Please, you have the floor.
Yes, okay, thank you for again. And 2 points, and Dr. Virginia just raised the issue about the technology and people. And I have observed that we give people their blood pressure monitors, their glucometers, but there's no follow-up instruction to say that they properly understand, and they stockpile these technology in their homes. And one of my patients, okay, she's in high 80s, maybe early 90s, have a cell phone, yeah, but just to send me a WhatsApp message, she couldn't appreciate that. And so came to my office recently and sat down and walked her through how to connect to my Wi-Fi in my office, because she didn't realize that I have Wi-Fi and that she could get free access to WhatsApp around me, so she, and then how to install my contact properly in her phone. Yes, she had my number there, but it was not installed as a contact. And so she couldn't search me for in WhatsApp because she didn't know how to. So these little simple things need to be done, and having a digital community health worker is important, where people out there will go and work district 2 or 3 homes, and that's their field, and say that these families know how to navigate the technology and that they are being properly served. And back to your point, Claire, about how the pandemic was managed. I mean, all these lockdowns were a bit going over the top, because I mean, as healthcare workers, we work in a high-risk zone, and all the infection prevention control protocols, we know them already. We practice them every day in the operating theater. And people were hoarding PPEs instead of giving them out to the healthcare workers and say, look, protect yourself. You're going into a hazard zone, put on your full face mask, but there are PPEs stockpiled waiting for the grand crash, which was unnecessary. But keep the health workers on the front line, teach them, point them on the safety techniques of how to test frequently. But they banned testing. They were only doing PCRs initially, when they should be doing antigen and antibody profiling to see where people are at in terms of their infection course. And so only towards the very late stage of the pandemic, they start to release the antigen and antibody testing. I mean, I pick up a few patients because I dare enough to do the antibody profiling. They came to the office and antigen test was negative, but they had symptoms and they said, look, this could be COVID. I have a friend in another island who have a lab who do antibody tests. I said, let's try it and see. And sure enough, came back, the antibody level was sky high, and they did indeed have COVID, and they were having end organ complications, which we were able to stabilize because we had that knowledge that yes, they were having nephritis from their COVID and other complications. But because we did the antibody testing, that's how we were able to make that COVID diagnosis. Because we had passed the window for the PCR and for the antigen positivity.
So in terms of care, then, as we think about the Caribbean region as a case where we are supposedly middle-income countries, right? But our healthcare system not so much like middle-income countries' healthcare systems. I think the opportunity for the diaspora, who's already engaged in providing medical missions, may really be right now to deepen the conversation with governments, to have people like a Dr. Vigilance be in the same room with people like yourself, right? You are probably part of the OACS healthcare system, and the OACS healthcare system is much more integrated than, say, in Jamaicans with other islands. And I start there because it's a smaller group of people. They already work in a particular way. Procurement is done in a collective way. I'm wondering if we can't begin to think about elements of pilots that we could begin to test so we can provide information to the World Bank and PAHO. One of the things that, again, offended me as an individual watching was the fact that we were asked to do tests of different tests, for example. So when we have to test the test to make sure the test itself is, a good test. But we as a region were not strengthened in terms of the capabilities of the labs so that they would have a dual purpose for us after the crisis. So it's like, again, the research apartheid, I call it, where the high-level research, quote unquote, is done to benefit the deep pocket companies and the nascent researchers that people are doing. And we're going to talk about integrative things later in the day. But one of my areas of real concern was the fact that cannabis and other people working on other, herbs have been doing a lot of research on the ground at the University of the West Indies and UTech for a long time. When I asked, are you being supported to look at how our traditional medicines could be used to also be a first case responder then, okay? This bush tea is good for cold. Let's have someone look at it because we're not gonna have enough vaccine. We're not gonna have enough drugs. We're not gonna have, and some people will die from the vaccine. So again, is the Dr. Liebert, are you hearing this conversation in the Caribbean region among doctors, ministers of health? I mean, what is being whispered? Because certain things, people are not going to say publicly, but is any of this conversation being talked about, or is it just an assumption that, money will come from the World Bank, which is not free money, to pay for this stuff?
Well, I mean, we have, I say, the research appetite that if it doesn't come from the CDC or the NIH or the FDA, we don't want to accept it. And we have our own scientists who have trained to the same level with PhDs in the Caribbean. We have access to our whole, our whole ecosystem of plants and animals in the Caribbean, which have a wealth of pharmaceuticals embedded in the plant, in the flora of the Caribbean, which have been taken from us, brought to the labs in the north and processed and sent back to us in a capsule, in a tablet, or injectable. And we accept that, but we don't want to start the process ourselves. And that is a great travesty. We should be sending our students out into the forests of Jamaica and Guyana and through the Caribbean and collecting all these, medicinal plants and looking at them and trying to extract the compound and see how they use, or trying them in different formats, listen to the old wives' tales of how Granny used to do it this way and that way and the results they got and so on. And it's a wealth of information out there that we are ignoring because it's coming from the poor job lab, barefooted Bob in the street, and we think that they have no role to play in the system. And we need to change that mindset that everyone is a stakeholder and everyone has something to contribute. And and respecting our population, respecting our people, that not because they didn't go to university like us, that they could add to the conversation because is their body. They may not know how to interpret the symptoms and signs that they have. And that's where we come in. But everyone knows where they have traversed in life and what they have done or not done. And they know they have, but sometimes they are afraid to disclose certain habits which may be deleterious, but then you sit them down and you reassure them that we are partners in this together. I mean, you have to disclose, you have to tell us, and we will help you to understand. And that level of respect and conversation has to be part of the way forward. We can't go back to the old paternalistic way, and COVID has come to expose all these systems. Everyone was affected, everyone had to face the lockdown and the uncertainty of what it is. But now, going forward, we need to make sure that, we can't leave.
Yeah. But one of the things that's come out at me is also the new technologies in research capabilities. So telehealth has to be a spectrum. There are no technologies that are able to do certain research online. Like there's some new technology that allow people to study chemistry online. We never thought we could ever do chemistry online. We thought chemistry had to be in a lab, right? A physical lab. But now we have new technologies that allow us to do virtual VR, AR enabled research labs. We have robotic surgery that's now being tested. So the question is, Dr. Vigilance, when we look at the telehealth as a spectrum, right? What are some other things you would like to put on the table for us to think about? Because there's no point in us starting a conversation and look at it from a piecemeal. We need to look at it from an ecosystem perspective and then say we're going to tackle this section first, that section second, that section third. But paint us a picture of the other things that make up the ecosystem of health that can be put online in using technology to make it more accessible and equitable for people who are not in areas that are fully served right now.
Yeah. I really love Dr. Leibert's comment about everyone is a stakeholder and everyone should be part of this solution finding. And then I want to channel Dr. Peart in the chat, talking about the power of the region. And the reason I want to highlight those two things is because a lot has been made recently, particularly in the pharmaceutical and medical device development world and the research world, about clinical trials and decentralizing clinical trials. Now, typically, clinical trials are, if you sign up for one, you sign up at a particular center. You have to go back to that center to have maybe blood drawn or other things that take information taken from you. And it's very much about the access to that particular location might be an issue for you. You may not have transportation to get to it. The times that they want you to go may not work with your work schedule. You may not be able to get away from family, etc. So centralized clinical trials are becoming decentralized, meaning that tools are being put in people's hands to be able to participate in clinical trials from where they live, from where they are, without having to go anywhere. Now, why is that important? It's important because we talk about edge technology, as I mentioned before. We talk about the power of the individual, as Dr. Leibert mentioned, and the importance of the individual stakeholder who holds in their hand a device or accesses telemedicine, telehealth, or some other, touches the system through technology. This allows us to significantly increase the number of people who can be engaged in clinical trials. And clinical trials aren't just for drugs, they're also for medical devices. They can be for other things as well. So this is not about testing you and doing something spurious. This is about increasing the diversity and the inclusiveness of scientific inquiry, a process that has been typically skewed towards communities and populations that have been able to engage in the centralized clinical trial. And that may be because it's been put in front of you, because your provider is at a large university center that has clinical trials at it. But you may go to a community provider who's not necessarily as tied into a university setting, but this decentralization enables that community provider to also put these sorts of things in front of you. So I believe that this decentralization of things in general, finance, medicine, care, everything, is also going to take over the clinical trial space to some extent. And there are many, many systems here in the US that are investing in this. And I think as a region, the Caribbean has enough people and enough power, right, and capability to enable for this sort of thing to happen, but on a regional scale, because the number of lives and the number of people that these systems are talking about impacting in the US are in the hundreds of thousands and millions count, right? And if we want clinical trials to be effective, I don't say that the number of people has to be that high, but N certainly needs to be not only of a certain magnitude, but of a certain diversity.
Variety of people. Yes, and that brings us to the point that's so interesting that you say that, because I had the esteemed opportunity to bring to create a small CRO in the Caribbean. The sustainability was the issue with regard to continuing, but with the decentralized clinical trials, it has opened up a new avenue for valuable, very valuable information from a very rich region to be able to participate in. So let's see, Dr. Liebert, I believe you had your hand up. Yes, and I know there's a lot of chat going on back here. I'm going to read it and see what we're talking about.
I kind of like the way the conversation is going in terms of the decentralization of clinical research. And frankly, I know the hurdles we have had to face, even to get a little project approved in St. Kitts and Nevis. And these things need to be taken care that there's this phobia about research, or we are creating lab rats or guinea pigs of the population. And I tell people that everyday life is about experimenting. We do it every day. We try new menus in restaurants, so we try new clothes and so on. So life is about experience, and experimenting is part of that experiencing of new things. And so the fear of research in the Caribbean needs to be broken down. That we need research, we need to control the variables, we need to collect data so it could be properly analyzed. And
absolutely.
And we need to kind of build that into the technology framework where we have devices that could sense things in the environment and your person at home and feed that back into a coordinating center where we have the epidemiologists, the scientists, the statisticians who could analyze this data in real time and give us quality information about our population and how they're being impacted by whatever situation exists,
Absolutely. And I think that we have the opportunity to prove that and lay down a template, and we have done the proof, and it does work, and it can work. So we're gonna come visit that again. I'm very excited about that. We'll see how it goes. One statement that I did want to make is that my 2 cents is that with moving towards artificial intelligence, telemedicine, and such, I embrace the schemata that Dr. Vigilance described, where the patient is dealing one-to-one with the physician. They're coming to some conclusions, prescribing, but there is the hands-on piece that is always at risk of being replaced with a machine, and it is an important piece that I think we should, once again, people need technology, and technology need people, but people also need people, and having that piece being always considered in the configuration, I think is going to be important in any type of project or program that's put
Well,
together.
I don't think the Caribbean right now is in danger of the healthcare system being AIized, right?
Yeah.
I think that's more likely to happen here in America because as we were talking about this on Monday with Dr. Moore, he was talking about the healthcare industry driving for profits. And so doctors like him who practice here in America, he's very much an old-fashioned doctor. He sets aside so many minutes per patient, and that's why he sometimes can't take insurance because he has a standard that he says, I need to spend, 25, 30 minutes with my patient if I'm only seeing them once a year, not 10 minutes. And so that question about us here as Caribbean people here, we do need to pay attention to the law, the policies, the way things are being done in healthcare. And I think one of the things we need to be mindful of is, as a community, is to start going out to these hearings when our state governments have these hearings on insurance or healthcare. We need to not just assume
insurance.
We know nothing, but I'm saying some of us who are in the healthcare industry who can educate the rest of us need to at least, even if they can't, speak publicly, whisper in my ear, hey, Dr. Nas, get this on the road. You can't say you heard it from me, but you need for your people to know. Dr. Vigilance, I saw your hand go up right away, so I know you have something to add to this.
I wanted to gently push back on the idea that the Caribbean is, or healthcare in the Caribbean is not yet AIized. I knew what you meant by that. Facebook, Instagram, TikTok, all these social media platforms, LinkedIn,
Right.
a number of others are already in play. Now, what do they have to do with healthcare? We talk about the funnel. The funnel.
No, you're right. You're right.
How do people access care? And typically that's been through word of mouth, maybe, or the emergency department or somebody else. But those funnels are influencers, the things that influence people to go for care. And some of those influences are now very much more social than they are otherwise. And if we're collecting any data on anybody and it's going up into a cloud, be it a clinical cloud, a non-clinical cloud, a social media cloud, or whatever it is, there is probably a bot of some sort being deployed and an algorithm, a machine learning algorithm being deployed into that cloud to learn what's going on in there. Why? Because that data is the new bacon. That data is where the money is. And so folks are looking to that data and to learn from it, sometimes for advertising purposes and marketing purposes, sometimes for research purposes, etc., to be able to do various things with it. And that's I think why I hear what you're saying about maybe the sophistication of the electronic health record in the island.
I stand corrected.
But
I stand corrected.
It's there. So I think that it's
I stand corrected. You know why? Because in fact, you raise a very important point that is also the influence of the system. When we had at the time, there was no, let's say, repercussions for false information. We don't have like a health scare law in the Caribbean. I mean, these things we hadn't thought about before. I think the US may just be putting those things in place now because of COVID. Certainly the providers like the YouTubes and the Googles, they don't want to be sued. So they're putting in place their own, let's say, filters and healthcare experts to be on panels. I mean, I found out that one of our own quote unquote icons in our community, Dr. Garth Graham, was at one point the healthcare czar for YouTube. And I'm like, why would it need to be a healthcare czar for YouTube? I said, and he got this right in the heat of COVID. I said, because of all the false information, they had to have somebody who's a public health expert be helping their team to know what to filter, what to censor, what to push, what to pull, etc. And so you're right. It's not just we don't have AI in the surgical spaces yet, and we don't have, digital health workers yet, although I'm hoping that this group at the table can help to create a digital health worker program, because NCU, Northern Caribbean University, has a very strong nursing training program and a very strong allied health program. And they have a very good IT department. And they also have a high school. So I think they have a mix of things there that they could probably be a good, and they also, as an Adventist school, have a hospital. So they could be a little bit of a microcosm of an ecosystem that could begin to test out, can there be a sample of this technology-enabled smart community health? I want to throw out the word smart community health system that the diaspora who's already doing medical missions could become a part of. Because take it from me, my sister does medical missions in Portland, a very rural area where the road is washed away half of the time, right? So when she goes on medical mission, she comes back, then she, of course, she's been going for several years, so the patients know her. And invariably I get a text from her, one of my patients died, and she's crying, I because I never have no test, I because I never have no. So I already know that those diaspora that have been going to Jamaica and Guyana and Haiti for a long time have relationships that could benefit from us finding a way to get started. And maybe not a big way. Find a way to get started. If the doctors have already been approved by the governments to go down and do missions, then they should be able to be approved to provide telehealth medicine in the region as well. That's an issue of concern to me, because there are charlatans who will say they graduated from Harvard Medical School and they spell it HAVERD. And you, of course, you see HAVARD because that's what your brain is trained to think. So the person hasn't lied. They didn't put they graduated from Harvard. They put Harvard or Harvard Medical School. And you think, oh, it's a Harvard graduate. And so end up with a charlatan. So I don't know, Dr. Vigilance and Dr. Liebert, what are the regulations and laws that are in place? Do we also have to be starting to have this conversation using, again, technology to be able to check into these people who come down to the region, nobody knows them necessarily, and claim to be, healers of one sort or another? How might we build this into the conversation of creating a telehealth system that can provide services, get us started, but at the same time, not fall into traps where unscrupulous people can now take advantage of our people? Your thoughts on that? Dr. Liebert, you first, you're on the ground.
Let me jump in here as one who has to traverse health jurisdiction, that the medical regulatory bodies, medical council, medical boards, and in the Caribbean, they're interconnected. They have the CAMC, which is trying to put standards for the Caribbean region. So that graduates coming in, they meet a certain level, but the ability to vet the training program that these graduates come through, I'm not sure how robust that is. But governments have resources and they have connections which they should be able to put in place the appropriate infrastructure to say that a person who comes out with a paper saying that I'm a medical doctor or a dentist or whatever health practitioner they say they are, that they have been to a recognized, accredited form of training. And I know yesterday when you were discussing the stackable credentialing processing and so on, that a lot of online work is done now, but with the practicum, with the competency, demonstrated competency of being able to spot a problem and recognize it. Yes, you could get a degree online, without having touched one patient, because that's the way technology is going with education. But the hands-on experience, being able to process that information and implement your knowledge to real-life situation, that's where we need to go. And maybe practitioners will have to go through a period of internship or probationary period where they're observed by the local jurisdiction to see if they are fit for purpose and that what they claim they are is really so.
Francine, I saw your hand up.
Yes, I wanted to piggyback what you were speaking about before. I think during this quest to put this session together, I was telling you that, and I'm just so excited about the possibility. But I think we have hit a good vein of participants to help us look at what the future could look like. And the group coming under Dr. Ed Stevenson is the group that I'm thinking about, that we're going to hope to gather some more information about, collaborating, because they already are partnering with many of the major institutions that are going to be very important for the region to be able to liaison into. And I'll give you more on that at another time. I see Dr.
Yeah, I'm so excited. Dr. Edwin Bakongo is here. Yep. These are my friends, which we met in the height of the pandemic 2020. So back in 2020, April 12th is UN Health Day. And I was really frantic. I got frantic because there was this person in France who said, let's test the medicines in Africa. And I went, let's test the vaccine in Africa. I went, oh no. And so I started looking for African people who were doing stuff to say, hey, what are you guys doing, right? Ran into this organization called Diaspora Care, who are trying to really use their expertise here as doctors, as IT people, to provide telehealth and regular health as well on the ground in Africa. And so I was able to invite Dr. Edwin Bokongo, who is a member of that team. They have something called Clinic in a Box and Pharmacy in a Box. And I wanted to know, I haven't talked to them since last year, so a lot could have happened. I want to get an update. First of all, just give us a brief overview of what Clinic in a Box is and Pharmacy in a Box is, and let's see, and what has been happening. So we see how might that be another solution in a post-COVID world, that the Caribbean can learn from what you guys are doing, and we can have a Caribbean version of that. So Dr. Edwin Bakongo, welcome. We've been talking so far about telehealth largely, how it can be used to strengthen access to the people who are unserved or underserved. Dr. Vigilance is an expert here in the US in this area. He is a public health expert, a medical doctor, and has worked in many different cities, DC, Baltimore, in many senior capacities. And Dr. Glenville Liebert is based in the region, in the small island of Nevis, and he's a medical practitioner, not a public health person, but of course his years of experience in a small island make him also a public health expert by vocation. So that's the background of who we're talking about. And again, the purpose of this conversation is for us to gather data from this conversation, from the chat, from people who are attending, to update our advocacy paper, because we want to take this information, rewrite our segment on telehealth, which we first wrote 2 years ago, and know what to advocate PAHO, the World Bank, the IDB, and USAID for the region. So we have a goal here. It's not a conversation for the sake of having a conversation. We're trying to figure out what are the kind of programs and projects and policies we ought to be advocating for. So with that, tell us a little bit more about where we are with Diaspora Care's Clinic in a Box and Pharmacy in a Box program. The floor is yours.
Okay, yeah, thanks. Thanks, Dr. Nelson. My name is Edwin Bagonko. I am actually originated from Kenya. Been living in the States since the end of the last century. It sounds like a long time. I did do my medical school training in Kenya. Practiced for a while before I came over here. Now I practice internal medicine in the Twin Cities, Minnesota area. And I also got a chance to, detour and go to business school along the way. So I'm really in the intersection between healthcare and business. And that's something that has always been, part of what I've done over the years. Diaspora Care is a platform that really began from frustration by most of us who live here, sending money to our loved ones, and the money intended for healthcare was being diverted, and in the process, you can't really feel confident that the investment you're making in the health of your parents or your family is really happening because they've got other needs. We wanted to create a platform for individuals to sort of separate health from other needs so that at least the piece of healthcare is seamless directly from those of us who live here and those that actually provide care. So for example, today, my mother goes to see a doctor. I don't send her a single dollar. I engage with the platform and I pay the doctor, I pay the pharmacy, I'll pay the hospital directly. So my investment in her health is not in question. The second piece is that our original beginning was really to create access to safe medicines. So we started out as a quest to sort of eliminate the ability for fake medicines to make it into people's hands. And if you don't know, more than half of our African brothers and sisters access fake medicines. So I wanted to create a profile of pharmacies that have the ability to sort of guarantee safe medicines. What we found is that whatever pharmacies we were going to try and engage, some of them in very remote areas. So I'm sure you've heard about the whole concept. I mean, we all know about the whole conversation about health equity and health access. And the idea that if you're going to reach people in the last mile, you need to find a pharmacy that is also close to them, if they live in the village. Most of these pharmacies have no systems to determine how much inventory they have. It's sort of depending on who in the village really needs what medicine. They kind of have a very disorganized way of sourcing and stocking medications. So we have a product called Pharmacy in a Box, which is really a pharmacy management system, which you can install in any pharmacy and give them a chance to actually organize their inventory, their stock levels, and start having a chance to really operate like a business, right? And this Pharmacy in a Box is an operating system as the size of my mobile phone, right? It's very tiny, and it has its own battery. So if the power goes off, it continues to work offline and until power or internet access is restored. So it was important for us to offer pharmacies that didn't have an electronic way to keep records, a solution that was cheap and affordable. Some of the bigger pharmacies already had systems, so it wasn't a big deal. In the process of doing this, we found that our customers, who are those citizens living in the diaspora, just didn't want us to do pharmacy. They wanted us to work with doctors and clinics. And we had the same challenge. Some of the clinics still had the old system of you have files and papers and you can't tell which patient came last month and that sort of thing. So we expanded our offering to involve a clinic management program, which we call Clinic in a Box or Clinic in a Cloud, depending on what options the clinic chose. But what we've tried to do is then to create this technology footprint that allows people not to be paperless, but also to help us collect data just around, diagnosis, what percentage of people that go through partners of this condition or that condition. So we got that. As far as the investment in health is concerned, we found that some of us who live here might have siblings, for example. So Diaspora Care as a platform has also allowed them to generate what we call wallets. So if there are 3 of us living here, we can actually share a single wallet, donate to that wallet, and assign one of us to be the custodian of healthcare spend for our loved ones. So as we have developed this infrastructure, we also realized that in order for us to develop a much better pipeline for this, this healthcare investment, it's not enough to assign or onboard a doctor when we know they have challenges, whether they would be diagnostic challenges or, as you can imagine, I see a patient and they have a condition I don't recognize. They look sick, I have all these lab tests, and maybe I'm missing some points as far as a diagnosis that can unify what really brought them to the hospital. So hence the intersection with telehealth. So we today have a platform partner that allows us to provide a second opinion. So this is how it would normally work. Let's assume I have a doctor in Kingston who is seeing my mother, and he says, you know, I've tried this, I've tried that, I'm not sure what's happening with your mother, and I think they have a rheumatologic condition. And I don't have access to a rheumatologist, for example, just as an example. The doctor can seek a second opinion. Right now, we think it's better to have what's called a peer-to-peer second opinion, because one of the things we've learned in our Kenyan experience is that the physicians who serve these communities have worked really hard and made sacrifices just to stay there and provide care. So if you have a telehealth platform that competes with them for patients, you're really unplugging the infrastructure for access, because they depend on those patients also to maintain their own, to make their practices viable. So we felt that our strategy has to be more complementary and provide a peer-to-peer sort of second opinion support, which we are currently in the pilot stage of doing. I think what it does is it allows a little bit of cost control. It allows a little bit of organized follow-up, as it were. And the supporter, for me, who is paying for the care, I have visibility because it's happening on the Diaspora Care platform. So that's the way we are structured right now. Another piece of the puzzle is those that really like to manage their risk, right? They want some element of insurance. So we have partnered with one of the largest insurance companies in the continent to provide insurance products around medical insurance, around life insurance, with the intent that those that want to budget for a health budget that predictive whether they get sick or not, there are those of us who just like to manage our risk. We want a fixed fee, want to pay and not worry about whether costs go up or down. So we're looking at the whole spectrum of what is it that we can do here to better take care of the health of those that we left behind on the continent, and that's our Diaspora Care platform in a nutshell.
Wow. That's all I can say. Well, you guys have done a lot since we first met, and I'm so excited. We're coming up on almost closing time. We have about 10 minutes before we have to close down. I really am glad you're able to come, because I'm sure both Dr. Liebert and Dr. Vigilance brain is turning. I'm turning here and saying, okay, we don't have to start from scratch in the Caribbean. Right. We need to have some conversations about how do we bring this to the Caribbean diaspora who are facing this issue. And you said something very important, that those doctors who choose to stay and provide service at home should not feel that they're competing for patients. And I do think that that would be a really good way for us to institutionalize a process, because one of the challenges when you go on a medical missions, sometimes specialists go on medical missions to Jamaica. They're really specialists, right? But because people haven't seen a doctor and they hear a doctor come from foreign, right? They come with all kind of malicious complaints that really don't require a specialist, right? And so then they try to direct them to see a regular doctor, but there's not this ability or willingness to do the spend. And so I think this idea of also including the insurance, some kind of insurance product, that the diaspora is not surprised, because I've been telling people in the diaspora, we have to organize ourselves to recognize that as we get older and our earning power changes, right? The people that we've been taking care of cannot expect the same level of response, because once you retire, usually your income drops by something, some amount, right? It's never the same. Most of us have no big savings. And so you're still responsible for your grandparents or your grandaunt or your cousin who grew you or something, but you no longer have that extra $200 cushion to, send home at will. So how can we create a micro insurance product or partner with an insurance company? So we're putting like a drip every month with $20 or $40, so we don't have a shock of being asked to send $500 when some crisis happens. So this, I think, is a very good idea that you have put in place. Dr. Vigilance, what is your thought when you heard this conversation? What came up for you in your mind?
I really loved this idea of this wallet, and it's sort of very much like, I think, without knowing the contents of it, but similar to this personal health estate that we talked about before, the data estate, and the information that would be in that wallet, and the ability to the control element of things. So it was it allowed for an individual to decide or give proxy or authority to a couple family members to be able to access that information and potentially share that information. But the individual themselves, if I understood you correctly, Dr. Bogonko, is able to share that information as they see fit with who they want that information to be shared with. And I think that's again part of this path to really owning your health, if you will, to some extent, and owning the ability to interact with the system in a way where you, to some degree, set the rules as opposed to the system setting the rules for you. So that was the thing that when you mentioned the wallet, I was just like, okay, yeah, that sounds really promising.
One thing that came to my mind, I'm going to interject here, is insurance keeps coming up in a lot of our discussions. And I'm thinking that as things change, insurance needs to adjust and change, and whereas I'm not, should you say, very, very exposed to the insurance industry, is healthcare insurance and life insurance. But I do believe that it is an area that is going to need constant tweaking and adjusting to serve the communities that they serve as things change. And so we want to make. I like that. I like that the insurance aspect is of great consideration. I think we need to look at that further, because insurance, like it has come up so many times, continuing in our discussions. Okay, let's see. We are just about 10 minutes away. We got to close down soon and prepare for our next sessions. If there's let me see if anybody has anything on the chat.
Yeah, I think there's a question about. Go ahead.
Hi, sorry, this is Ewell. Just listening to everyone and some miraculous things happening in the medical field, that is absolutely great to hear. From a futurist standpoint, I'd like to say that some of the difficulties about the medical advances is that we still see medicine being practiced in brick and mortar buildings. And we need to totally disrupt the entire medical process of billing and the way the system works, which is why it's kind of out of reach for people to pay for some of the most basic of services. From a futurist point, I would say that the advancement of Apple Health, for example, or the advancement of the iPhone will be much more advanced to the point that remote needs in the Caribbean or the remotest points of the earth telehealth may be able to ask a person to take their iPhone or whatever kind of device they're using and actually scan and take x-rays of their internal organs and get a self-diagnosis right there. And that happens at a very limited level now. I think it's going to be much more advanced in the future. Even to be able to do dental x-rays via iPhones and actually take photographs of yourself. And I know that we've come to accept it as we travel at airports, not realizing that airports can actually take skeletal images or organ images based on how intense they set the scanners. So I just would say that as we move forward through some of these technologies and the wallet that was being discussed earlier, which may help with kidnappings, we do know that a lot of people get kidnapped when they send money back and forth. So if some of the money can be truly electronic so no one can see it, that might help save some lives on the small end. But I think that the advance of the iPhone hasn't been tapped yet. I think there's going to be a lot more advancement coming down the pike. X-ray technology still has not advanced the way we need it to moving into the future. And we need to, again, just disrupt everything we know about medical treatment, the way it's advanced, the way it's brought, and look at that as we move forward into the future. Thank you.
Yeah, I was just gonna make a comment, and that is, it's no longer possible, even in a country where this year we're gonna spend $4 trillion on healthcare here in the United States. We can't churn enough doctors to meet the needs of the community. So we have to go to the next level. So we are having an explosion of training programs of nurse practitioners, physician assistants. We are going to see an explosion of people whose only expertise is delivering babies. You're gonna have people who go to school just to be a midwife. They don't have to be a nurse. They're just gonna be trained to deliver babies. We can leverage that reality a lot better in underserved communities. This is what is happening here in the United States. And back to the iPhone and technology, I think to the extent we can have that infrastructure of expertise at different levels, maybe it's the village, the ladies in the village who can be trained how to deliver babies safely. Maybe it's a nurse practitioner who is based in the village who can be trained to create the necessary conduit for interaction between a device and, say, a medical expertise sitting somewhere. I agree that we have to look at linking the idea of medical care to an actual physician being present. We have to allow these different levels of people who are interested. As we all know, the majority of people who get sick and die from preventable diseases, right? Even if we trained a high school science teacher to recognize the symptoms of malaria early, he can direct a patient to get care and avoid all the morbidity associated with it. So essentially what I'm trying to say is technology and creating a much easier way to allow more people to be involved in this precious thing we call health at different levels can allow us to reach even the remotest places and then leverage technology so that at any point in time, the right expertise plugs into this continuum. I think we can solve a lot of our healthcare problems.
And you know what? We're going to have to really shut down now. I know Dr. Vigilante was supposed to be somewhere else a long time ago, so thank you for staying on. Dr. Bagonko, you came at the end. I'm so happy you did make it because this information you brought forward was so important. Dr. Liebert, thank you for joining us. Please stay on for the next session and lend your voice there as well. We'll be talking about healthcare engineering systems management. You're a surgeon, so this is going to be very important to you. I just want to say thank you all for coming. Thank Francine for doing an able job in stewarding the conversation and getting us started. We're going to turn down our stop our recording and stop live streaming. and get ready to prepare for our next session. So thank you everyone for being here. Take care.
Thank you.
Bye-bye.
We'll
be in contact for sure.
Thank you very much, everyone. And I do appreciate it. Dr. Bogonko, nice meeting you. This platform.
Thank you.
Thank you. Enjoy your
Thank
presentation.
Thank you.
Yes. I loved everything I heard. It was great.
Thank you. Thank you.
Yes,
Thank you.
Definitely need to talk. All right. Take care.
Okay, wow, this is such an exciting session. Just to understand that we